Great. I think we can get started. This session is on orthopedics and physical therapy, and we have some wonderful panelists joining us this morning. This is set up as a Q&A, so your questions are encouraged. We'll start out with having each of you introduce yourself and share why you joined your field, and then we can open it up to questions. Tina, do you want to start?
Check. Can you hear me? Hi, everyone. My name is Tina Duong. I'm a physical therapist. I currently direct research and outcomes development at Stanford during this time, or I guess now in my life. I feel like the physical therapy field kind of chose me rather than I chose it, and particularly the neuromuscular research field. I had no idea what I was getting into on the day I interviewed for a job I wasn't looking for, and so now 20 plus years later, I'm still here. But I think the reason that I find physical therapy, especially in this time, that's so important is that we look at regenerative medicine or rehabilitation, being creative to get people to be able to do things that they want to do to stay active. And during this journey of mine, I think we've come back to the core of why I became a PT. So I think at this moment, it's really exciting for us as rehab professionals because of the changing landscape and how much more of an impact we could make in that area.
That's good. Hi, I'm Megan 𝗦𝗫𝗻𝗻. I am a neuromuscular physical therapist, research physical therapist, and I became a PT because I just loved it. I mean, I really wanted to, I like working in research. I like working in clinical trials that are advancing medicine. I like working in natural history studies so that we can prepare for those clinical trials. And I really like the clinical care aspect. I like being able to work with families and kind of problem solve any difficulties that they're having in the home. So, yeah, that's it.
Hi, I'm Brittany Gallos. I'm a physical therapist. I've been working for about 10 years now. I was an elite level athlete before becoming a PT and thought initially I'd go into sports-specific physical therapy, and then had clinicals in the pediatric setting and fell in love and never looked back. I have specialties in scoliosis therapy, and I've always found myself drawn to individuals with scoliosis or with rare disease. Bonus points if you have both.
Okay, my name is David Spiegel. I'm an orthopedic surgeon, and I've been practicing for about 25 years, and I'm from Philadelphia, and I work at Children's Hospital. And I guess I got interested in medical school because I spent 1 year in an orthopedic lab. You know, we didn't get exposed much in medical school, but that was my introduction. And then, you know, I've found great interest in caring for kids with neuromuscular conditions over the years, in part. And as much as that, understanding and enjoying viewing things through the lens of context, having spent, you know, living in Nepal and having worked in 16 different countries and trying to understand how these and similar conditions impact families and communities in different parts of the world. So thank you for having me.
Hi, I'm 𝗦𝗃𝗀𝗏. I'm a physiatrist or a medical doctor in rehabilitation medicine, and I work in the Radboud University Medical Center in Nijmegen, the Netherlands, and also in a rehabilitation center. And my dad has a chronic renal disease, and he's already 86 years old now. And he always said, I'm very healthy, because he's exercising his whole life. And during my study of medicine, I always wanted to be a sports physician. But I express my wish that I want to help people with a chronic disease like my dad with exercise. And I met a man who is a rehabilitation physician, and he heard my story and he said, I think you have to be a physiatrist or a medical doctor in rehabilitation medicine. And I still believe that that was the right choice. And my research is focusing on exercise, especially to decrease muscle fatigue and pain in people, and also on mental well-being.
Wow. Thank you guys so much for being here. It's such a pleasure and honor to have you as our panelists today and to answer questions. So I want to encourage everybody to just raise your hand, and we have mic runners that will come around and ask questions. If there's any, I have a lot of questions that have been submitted, but if you have any now, please raise your hand and we'll get right to you.
Okay, thank you. Since I'm in a wheelchair and I'm sitting quite low, if you're able to stand up and just say your names again, because I can't see a face at all. I just heard a lot of voices. So it would be nice to have a face to the voice, please.
Thank you. We'll make sure to do that.
Can't we all sit on high chairs, maybe?
Well, I would love that. We have two. There's only two. There's only two. I would be happy to share this chair, though, if you want to come up here. Or at least there's two. So some of you can sit on a higher chair.
Yeah, just stand up, but it doesn't help either. So.
We're the smallest one.
And do you want to? You're welcome to come up closer too, if you would like, or anybody is welcome to come closer. Come up into the front row. There's plenty of space up here, so I definitely encourage anybody to come up into the front so you can see. And
Answer too.
okay. Yeah, and thank you, appreciate that. Well, I'll start out with a question to get things going. Oh, do we want to? Oh, okay. So why don't we just, for the sake of, so everybody knows who you are, if you don't mind just saying your name again, so that is communicated, and standing or sitting in a tall chair. Thank you so much.
I am 𝗦𝗫𝗶𝗙. I'm a physiatrist, a medical doctor in rehabilitation medicine, and a researcher from the Netherlands.
David Spiegel, orthopedic surgeon from Children's Hospital, Philadelphia.
Brittany Gallos, physical therapist from Indianapolis.
Hi, Tina Duong, physical therapist at Stanford in California, and I'm not going to hop up and down. That would be scary.
I'm Megan. I'm Marino. I'm a physical therapist, previously from Nationwide Children's Hospital, but in the past month, I'm now at UT Health San Antonio. Forgot where I live.
Okay, well, I have an ortho-specific question that we'll start with. So Dr. Spiegel, and probably mostly to you, but anybody would be great to contribute. Can you talk about the kinds of discussions families should be having around preparation for spine correction surgery? What questions should they ask to ensure the surgeon is prepared to effectively manage a neuromuscular patient as opposed to some other disorder that also causes scoliosis?
So I think that, it may be such that the surgeon is a technician and there may be a technical question regarding the spine, and the whole goal of spinal fusion, of course, is to arrest the progression of a problem where the natural history would be unfavorable on seating position, ease of care, or pulmonary function. Once a certain deformity gets to a certain point and we can predict what may happen down the road, then of course that might be offered depending on the age of the patient and so on. But to me, I don't exist without a system. Nothing exists without a system. And so I may have my role within that system, but I think the questions to ask are, does that system manage a lot of similar patients with similar medical problems, with similar social issues, whatever you want to say? And so, many of the procedures are going on in, bigger hospitals, university hospitals, and for example, protocol, if there's a lot of numbers or a lot of volume of experience, then of course, you want to know everything from the technical aspects of the surgery, what are the preoperative evaluations that are required, are there multidisciplinary specialists who will be available to help with the process of managing the patient, what about the rehabilitation, physical therapists, occupational therapists, rehab specialists. In other words, this is an entire process: pain management, aftercare, and so on. So if I were you, I would view it as I'm going to receive services in a system. What are the components of the system? And that would be my recommendation.
I have something to say. So I am particularly passionate about this topic, mostly because in our clinics, we were very separated. Our neuromuscular clinic was very separated from our orthopedic side of things, orthopedic surgery. And so sometimes we would have patients come from ortho and all of a sudden show up at their clinic visit and they are just devastated. They've had spinal fusion and they were devastated with the change in motor function and their change in ability to do daily activities. So we really tried to work together to bring these two departments together and discuss these possibility of surgery and how that's going to impact daily life. And so I think the good questions to ask are working with your physical therapist and your occupational therapist and seeing how your body is going to change following surgery. So if we have contractures in certain areas or we're used to using certain adaptations to feed yourself or to brush your hair or to get dressed, how is that going to change when we change the shape of your spine and we make you all of a sudden upright? Maybe you're not going to be able to access your mouth anymore. How do we change your seating system? How do we change basically everything about the way that things are being done for yourself? And we really want to make you, we're not saying, I would never say, recommend don't have surgery, but I would say, hey, let's talk together and see how we can make you the most independent and the most successful following surgery.
Couldn't agree more, and I forget if I said this or not, but I won't do a surgery unless the patient's been seen by all of my colleagues and everyone's had their input and everyone's on the same page agreeing that it's the appropriate intervention and this is the way we're going to get through it.
Yeah, yes.
Thank you for all your great replies. I just wanted to add to that as a community member is that facing spine health changes and surgeries are a big part of the muscle disease community, and so it is common. It's not for everyone, but that also, in addition to your medical care, it takes something for the family and your community, your personal community, to prepare for these surgeries. And you do really need like a village to support, and so planning, preparation, accounting for siblings, meal planning, how do you arrange things at your home, how do you manage being at the hospital when a loved one needs so much care, all of those things are, and what I would suggest is that you could really lean on your community for tips, because a lot of us have been through it, and I had people in the Cure CMD community who were moms that I reached out to. They gave me just brilliant tips. And then also our guides, the care guide for the congenital myopathies that's on the Foundation Building Strength for Nemaline Myopathy website, and for the Team Titan care section website, and also for the congenital muscular dystrophy guide. You can find resources on our websites about that, because there's all the medical aspects, but then there's all the personal aspects too. And so don't worry, we have resources and we can support each other going through this. So I want to thank all the medical professionals, but just wanted to say that from the community perspective.
Thank you, Sarah. I see a question in the back.
Hi, Adrian Gomez. My son has Nemaline myopathy. I have two questions. The week has 7 days, and every time we go to physical therapy, it's like, oh, we want the kid 5 days a week. And then we go to aquatic therapy, and it's like, oh, we want it 4 days a week. And then you go to occupational therapy, and it just goes and repeats itself. So the first question is, how do we decide which therapy should the patient be receiving? Which should be the criteria to select? Because we all have very different needs, and as a father, it's sometimes really hard to say, well, do I want him to be able to eat or to lift the arm or to be able to speak? How do we select that? And the second one is when things start to go very well and they want to increase therapy intensity. I have heard a lot of, we are doing this at sub-maximum. Like, okay, what the hell that means? Like, can we do 3 times now? Can we do 4 times? How can we make sure that our kids are not being overstressed on any sort of therapy and we take care of them integrally and not for a single portion?
I love your question because that's the question actually we ask ourselves all the time, and Nicole and I have gone back and forth on this, is your key word was intensity, right? And customization and personalization. I think when you have all these therapies, the primary person who's going to decide that is going to be you and your family. What are your goals? And then as your care team, they will help you prioritize, okay, of the 10 things that we were recommending, here's our 1, 2, 3, 4, and 5. So that when you have 2 hours in a day, what's the most important thing to fit in those 2 hours or 30 minutes, right? And so helping that prioritization is going to be really important. The way that rehab care, especially in the US, is it's not continuous care. Back in the old days with cerebral palsy, if you were diagnosed with cerebral palsy, your physical therapist is going to be part of the family. You see them every day, but that is not the case now. We want to be part of the family, but it should be like Christmas. You know, you shouldn't have to see us all the time. There should be kind of modal or multimodal type of care where whenever you see a therapist when you need or have a change in your function, and then you don't have to see them all the time. And then your question about submaximal or maximal, that's part of our job to teach you when you're walking, when you're exercising, what does it feel like to work in a submaximal level? Can you monitor your heart rate? Can you monitor the way you talk, the way that you feel versus submaximal? And to increase that intensity means that we have to monitor and measure how much you're getting better so that we know how much to turn that dial. Because if we don't, a one-size-fits-all does not work. It doesn't work for any of us sitting here on the panel, much less for you or your family. So it is a very personalized approach, and it's all about how you measure and making sure that that measurement is precise enough but not invasive to your family, because first and foremost your son should be able to be your son and not, you know, a patient all the time.
I talk to my patients and my families a lot about flexibility of care, how there might be periods in your life where you are coming weekly and there might be periods where you're not coming at all, you know, and that's going to ebb and wane throughout time. So I think, yeah, you have to decide what's important to you in that moment. If it's not mattering to you, speak up about it. Be your own advocate. Tell your therapist or your doctors if the things that we're working on aren't helpful so that we can shift programs and adjust to the things that you actually need. You know, I think one thing that has become really apparent to me over time is that what I think is most important for the patient isn't always what's actually most important for the patient. I've had times where I feel like, okay, yeah, it's, we're working on tying a shoe because this kiddo has a contracted hand, and to me that feels like a small thing, and then suddenly it dawns on me, no, tying a shoe with a contracted hand is a really big thing. You know, this is a big deal. This changes independence and function for this child. So having those conversations, recognizing what actually matters to those families, that click isn't always there. So you guys being the voice to us, guiding our treatment, letting us know what's important at those different times, and then we can use our clinical expertise to help let you know what frequency is needed for that, or what interventions or bracing or equipment or supports are needed to get there.
Yeah, very important questions. And I want to add that I always say my patients are top sporters in daily life. And exercise is not only about exercise. You have to have enough rest during your daily life to have an effect of exercise. And sometimes your daily life activities are already cost a lot of energy and are already exercise on itself. But sometimes there are aids, like walking aids or doing things in another way, or asking help to have more energy left to exercise. Sometimes I say to my patients, it's not the time already to exercise because your daily life activities cost a lot of energy. So let's see with an occupational therapist how you can spare energy to exercise. Or another thing, when we take a look at the daily life activities, we see that it's already exercising. And I always say the cyclists in the Tour de France, everyone understands that after a day of racing, they are not going to exercising in a gym. But therefore, we have to be sure that daily life activities are not already exercising, because when you exercise above that, then it will lead to overuse. So therefore, I do not always take a look at exercise, but also daily life activities. And how you can check if daily life activities are already exercising, for example, by wearing a heart rate watch, to see which heart rate you have during your daily life activities, or to feel in your body if you have a kind of muscle fatigue during your daily life activities, or to see how many steps you are taking during the day. So don't only look at exercise, but also your daily life.
Yes, and just to add another opinion onto that one, I think that as far as your son is concerned and your activities as a family and what's most important to you guys, I think from the submax standpoint, as long as your son is not exhausted, we're not going to therapy and then exhausted after therapy so much that we are, sleeping for the rest of the day, not engaging in time with the family, time with, if we're tired at school the next day, things like that. That's what we want to avoid. So we could do therapy all day, every day, but that's not going to help anything. So I think, we want to prioritize what's important and go to therapy, but also recognize that we have school and families and friends and all of these things that really help improve and is part of quality of life as well.
Thank you so much. Sure.
Thank you. My name is Anna, and I have NM myself. And I agree totally with everything you say. And I want to give some parents some tips. Everything you say that what we do, we exercise all the time. And when I was a child, and especially a teenager, I was really, really, really fed up with all your therapists. I'm sorry, but that's the truth. Because I had therapy, different kinds of them, 3 times a week. And one day I just told my parents, I'm fed up. I'm not going to do this. The therapy is not going to take my NM away. And I feel as a patient, even at home, when I have to exercise with my parents. So thankfully, my parents were good, and they spoke with all my therapists, and they got a program what I could do at home. I had to vacuum. I hated it. I had to unload the dishwasher and put up in the cabins. And in that way, I bent my knees.
Thank you guys so much for your understanding and compassion and help with taking care of Andre, Mark's dad. I'm glad that he looks to be doing well. And I think as Sarah started the session with a collective breath, it might feel good to do that again. I know I could use a collective breath, so I'm going to just do that now. That was an unexpected start to the day, and I know we would love to continue going, and there's a lot of questions, and so I think we can get going again with that. So, Nazia, did you want to go ahead?
Yes, hi. My name's Nazia. I have an 18-year-old daughter with NM. She was only diagnosed 3 years ago, but we'd got to the point where she started walking about 4 years ago, and had a scoliosis operation. Now, I love her orthopedic surgeon, love the team, but where does it come where you just don't quite, because they don't have the expertise in the condition, do you trust, not that they're saying anything wrong, but when do you push for more? And how do you do that? The reason I'm asking is that her walking is now degrading because of a pronated foot, hip issues, and things like that, and they say there's nothing we can do. But as a mom, you've spent all that time, effort getting her to walk and to see her regress because they feel there's nothing you can do. So where do we get more expertise? Do we need to look further afield? Where do you get that balance?
I'll take this one. As we mentioned before, we used to have a model of physical therapy where we were, 1, 2, 3 times a week, every week for the duration of a child's life. And we're definitely moving in our field towards episodic care or only care when we need it for, specific functional needs, which I think is definitely moving in that right direction. I do caution our field from swinging that pendulum too far the other way. And what I mean by that is that I see in the name of functional or episodic care, I see therapists losing focus on highly precise, highly tuned care. Meaning that if you have a kiddo and you're trying to get them to run across your front yard and that's your goal to have them play with their siblings, right? We just throw a brace on them that they can fit into and say, okay, you have more stability, now go run and play in the front yard with your siblings. And I think what we could still be doing and still in that name of, functional and episodic care is still pulling in those highly precise and highly tuned skills that we had from when we were with these kids 2-3 times a week, right? The background that we have in kinesiology, biomechanics, alignment, these things that make us specialized caregivers. We could see that if, for instance, turning the heel out a couple more degrees, which is something that a parent probably wouldn't pick up on, but as skilled therapists, we should. If we could get them in the brace in that position, now every step that they take, they're actually going to be stretching that tendon in a way that's actually going to be promoting movement out of an overpronated foot. Now, not only are they going to be running across the front yard, for the moment being, and check off our little goal of functional goal attained right now at 5, 6, 10 years old, but hopefully also in the front yard after their own kids when they're adults. And so I think that there's a delicate balance between, yes, of course, the goal is to move out of the clinic and to get into our lives that are much more focused on what actually matters, right? Not being in the clinic, not having, look backs like we heard from over here about just looking back in your whole life revolving around therapy. But there's also a balance there, and we still play a really important role in having that expert opinion, saying, no, we can throw a brace on, but let's optimize it. Let's make it as precise as we can so that we aren't just getting this goal checked off, but basically robbing you of the betterment that we could be causing down the line. So I think it's really important for parents, if you aren't seeing changes, if you aren't getting those things that you want, you need to speak up and say, no, this brace isn't fitting right. Her foot's pronated and you're putting her in a brace that's putting her in the exact same position of her already existing pronated foot. That doesn't make sense to me. How are we going to improve it? It's never going to get better than what she's walking on every single day. So what can we do? Is there a way we can tune it? Is there a way we can optimize it? So just seeking out those professionals that can have that nice balance between the two.
And just to add to that, us as professionals who spend our life in neuromuscular, we hear from a lot of parents, oh, we can't find people with expertise like you. That's great, because the expertise that you find is the reason why you go to a physical therapist. They have the skill set, but part of the education may be you connect them with somebody who understands the underlying pathology of the disease, or you educate them, so that's part of the process as well, so that they know if they're going to do a brace, are they doing it, do they expect the muscle to get stronger or better, or they are supporting a muscle that will not get stronger or better. Those are the key features that you have to understand the underlying pathology as well as what the goal is to find a happy medium. So it's a multi-prong approach.
I suppose the difficulty now is with her turning 18, she's only going to get therapy once a month, which is really, really tough, because then now we have to fund it ourselves.
And I think from that, if you're only getting it once a month, then I think that goal of that once a month therapy is to really work on fine-tuning what can be done at home. So spend that time with your provider that is attuned and knows your daughter and knows your family, to really work on, hey, this is what we're going to do this month, and this is what we're going to work on this month, and make that the goal instead of being it just a therapy session.
Thank you.
Is it on? Hi, my name is Lina, and I have a 12-year-old son with collagen 6. He has recently expressed interest in exercising with like little dumbbells, and he's really passionate about it. I think it's the age, it's the exposure, social media, just wanting to be a typical boy. He has learned of his diagnosis a year ago, I would say. So he knows he has what he calls muscular difficulty. What is the appropriate way to address his wants to be healthy? I exercise regularly, so I think, that may also contribute to, just monkey see, monkey do type of thing. But what is appropriate for him and how to balance his muscular condition with his want to be healthy?
I think that's a great question. I would highly support the active lifestyle. I think, as we were talking about before, is that are the dumbbells appropriate? Is that the muscle group that he should be working? Is it too much? Because part of it is you don't want that overuse syndrome or injury because his muscles are tired, so he compensates. So, like the guy at the gym that is lifting the weight that's too big for him. And so I think starting a program where you meet with someone who can understand from a strength program, how much can he do? And it's not just biceps, it's throughout the entire range of motion and what kind of support that he needs throughout that range of motion to accomplish his task. So it's very specific, and it may not be as he envisions, but he'll get there, right? That kind of explanation. And if it's strength training or if it's aerobic training, and also keeping in mind, he has call 6, but he also is a 12-year-old, right? And so growth plates, and you're still looking at the precautions for pediatrics in regards to strength training as well. So I think it's definitely a combination, but I wouldn't discourage an active lifestyle at all. I think that'll be utterly to his advantage, because if you don't have an active lifestyle, all of us will suffer from a disuse or a sedentary lifestyle that actually compounds the disease pathology already if you don't exercise. So I would definitely encourage it, but do it in a safe way. Have an initial evaluation with a physical therapist so that she or he can start the program, but also monitor it appropriately.
He's so passionate at this point that he would take his 1-pound dumbbells in the pool and do it in the water, underwater. So just anything, like literally very passionate. So I don't know, what's appropriate. He will submerge himself underwater just to see how long he can stay there or how long he can lift. It's
So, and I think sometimes we see. I don't know your son, so I can't make any specific recommendations. But I think sometimes we see exercise as very linear, like it is running on a treadmill, it is doing the stair mill, it is lifting weights and things like that. Sometimes it takes a little bit of reframing that exercise is not just being in a gym. Exercise is activity in general. So being in the swimming pool and, using the weights in the swimming pool, that's exercise, and I think that is wonderful. It's activity. It's whatever activity keeps the body moving, keeps the muscles moving.
So VR counts towards that activity, like VR gaming, where he just
Yes, like the
sweaty hands in the air.
Wii and whatever is now hip. Yeah,
It's exhausting too. So
it's exhausting watching him.
We incorporate into workouts with patients sometimes.
Yeah, and children as well as adults always look at the other peers, what they are doing. So, and sometimes they want to do the same thing as their peers and friends, family. But I don't know if in the US there are groups of children with disabilities who exercise together. Sometimes that's also good because then he compares himself to other peers with disabilities. And I always say, take a look at yourself and compare yourself with yourself and not with others, because sometimes it's not possible to compare himself with his peers, and that's disappointing. And the other point is that when you exercise at a young age, the effect is already there at an older age because you develop muscle satellite cells, muscle memory, so it helps that you exercise at a young age. So it's very helpful that he likes it.
Thank you.
Hi, I'm 𝗦𝗫𝗶𝗙𝗿𝗲𝗿𝗲𝗰𝗁𝗂 from Boston Children's Hospital. I work on the research of cellular myopathy, and I get lots of questions from patients. And the one that comes back very often is what kind of exercise would be good for keeping the strength in respiratory and spinal muscles. And from my point of view, what we know about the animal model is that there is a defect in muscle regeneration. So in that case, how do you deal with the physical therapy? You want to keep the muscles strong, but at the same time, if you overdo the exercise, you are going to get hit by the lack of muscle regeneration.
Yeah, the best way to exercise your pulmonary muscles is exercise itself, aerobic exercise, because then you breathe more frequently, deeper, and then you exercise your breathing muscles. But sometimes exercising is not possible or enough, and then we prescribe respiratory exercises for breathing in and out. And we see in our measurements that it has an effect in increase of strength of respiratory muscles or sometimes stabilizing. And that's also a good thing to know because being stable is already an effect in muscle disease, and that's not always a positive feeling because you want to be better, but being stable is also a big effect. And also in the Radboud University Medical Center, we now perform research in which we see that breathing exercises also help in swallowing function. So for a safe swallowing function, breathing exercises are also recommended. And the last thing is that it was already a question in the beginning, is that sometimes I feel that my patients have to exercise, breathing exercises, going to occupational therapy, physical therapy. You cannot do it all. So sometimes you have to choose which things you do. And I want to answer a question in the break, because the question was, what is a physiatrist and what is the goal of a physiatry? And we take a look at all the different things that help in increasing quality of life. And in the Netherlands, we supervise a team of physical therapists, occupational therapists, speech therapists, psychologists, and social workers, because everything is connected to each other. And we see what helps increasing the quality of life the most. And we help patients in making choices. And if there's no physiatrist in your city, then you can go, for example, to a neurologist or child neurologist who can also help in making these choices.
Hi, thanks for being here. We appreciate your time. My name is 𝗬𝗂𝗶𝗙. I have a 4-year-old son with NEB-related Nemaline myopathy. We are very fortunate that he attends physiotherapy 5 days a week and have seen a dramatic change in his strength from an ability to not quite hold himself up in sitting to now being able to stand unsupported. I have a bit of context there, and then the other piece of context that may be relevant is he's, for nutrition purposes, entirely G-tube fed. However, went from not being able to close his mouth and swallow to now being able to chew food and swallow it effectively, but not nutritively. My questions are, do any of you have experience with oral motor or oral placement therapy, and have you seen any research to support its success? I mean, anecdotally, we've seen it, but I'm curious to know if there's been any studies. And on the more orthopedic side, with 2 hip surgeries and a tenotomy coming up, I'm wondering if sort of the ongoing to tolerance therapy that he has been doing is sort of advantageous pre-surgery. Is there an advantage to increase it to tolerance? And I'm hoping somebody can speak to what their experience is around that level of therapy and the onset of scoliosis. Is there some correlation? Thank you.
Shall I begin with the first one, the second one? We know in boys with Duchenne that chewing gum can help in increasing muscles of the face. But facial muscles are different from muscles, for example, in the leg and the arms, because you use the facial muscles all day long. So there's a risk of overuse. So you have to follow if it leads to pain, muscle fatigue, but it's possible. And we just received a grant to evaluate the effect of facial exercises in children and adults with muscular dystrophy. So hopefully in 2 years we know the answer.
I can speak to the scoliosis factor. So weight bearing in and of itself is not dangerous for causing scoliosis. It's the asymmetric weight bearing that can lend towards that in our neuromuscular populations. So whether you're ambulatory and have a leg length discrepancy, or are only wearing a brace on one side and it's not totally symmetric with your other foot, or whether you're in a chair and your seating position isn't optimal, when you're weight bearing asymmetrically, that can influence progression towards scoliosis. So when we're trying to limit that, I would prioritize things that are going to be working towards symmetry over just broadly strengthening, say, core or glutes or something like that. So that can help you. We can also use it as a treatment in reversing. So say, for example, if you have a curve to the left, we see the people with left-sided curves tend to put their weight on the left, and then that curve's going to collapse faster because all your weight is on top of that curve. So if we can get that patient to actually shift to the right in their chair, that's going to unload that curve and save it. Doesn't reverse scoliosis, but it slows the progression, and in some cases, when done thoughtfully, it can pause it.
Yeah, and it sounds like you're doing quite a bit, which is great. I mean, if that works for your family, and that clearly is working for your son, that's amazing, or your child. So to address the surgery question, we always say to be as healthy and strong as possible before surgery. That period of immobilization following surgery can have a dramatic effect. So while I don't really know how you would fit more than 5 days a week of PT into your life. But I think what you're doing now is setting your child up perfectly for success following surgery. And then maybe once we start after another surgery, getting activity at what that is safe in as quickly as possible for the recovery period.
And I think I'll answer the last half of your questions, maybe. Your question about tolerance, and if you should increase to tolerance or sub-tolerance, sorry, I'm short even sitting on a high chair, is that I love your concept, because in sports medicine, we do prehabilitation, right, before surgery. And so I love that you're thinking in that direction. I think in regards to tolerance, it always should be dynamic and assessed. And so if you want to maintain, then you don't change anything. Then you just keep the program the same. But if you want to push the envelope and get stronger, you're going to have to measure how much can he tolerate, how much time, how much intensity, and really push that envelope a little bit there to get him up to that higher tolerance. And I think that's great, because he seems to be responding really well. But then you think after surgery, that doesn't mean he's just going to lie in bed. We all know that muscles takes forever to get stronger, but they atrophy quickly, right? And so what do you do while he's at the hospital? Strengthening is not just about an actual movement that you see. We know that isometric strengthening is the safest way to strengthen a muscle. So while he's in bed, are there isometric exercises that he can do to maintain his muscle health while he's in the hospital? So remember, it's dynamic, and it doesn't within the day, within the week. And so just keep that in mind as you're going through this evolution of some of his surgeries.
Yeah. And just one more note about the scoliosis. While, yes, there are things that we can do that can help slow the progression, perhaps, I just, from taking off my PT hat and putting on my people hat, sometimes scoliosis is inevitable. And don't beat yourself up over it. You're clearly doing as much as you can. Progression of scoliosis just happens in neuromuscular in people with neuromuscular disease. So I would just say that have some grace with yourself and your family, and it's okay.
And honestly, recovery is just as important as exercise. So just, I mean, you're doing a lot. And so if you came to our clinic, like, you know, it's okay to rest.
Thank you guys so much. We have about 2 minutes left. We're going to give a couple extra minutes after the session because of the delay. So we could probably take one more quick question, and then we'll want to move on to our next session. So, and then of course, if you don't have a chance to ask your question now, please find our panelists so you can have a chance to talk to them during the break. I think one more question over here.
Hi, I think it should be quick. It's really specific. My name's Krista. My daughter, this is my husband Corey. Our daughter is 17 months old, and she was diagnosed with collagen 6 mutation. So she's at the point where, like, we're working on like pulling up to standing, you know, the very early basics. So I'm a PT, but this is not my focus. So now I'm like researching everything. And one of the PTs I found, she was talking about like spinal stimulation, like NMES, but specifically for the spinal nerve roots. And she was talking about like hyperbaric chamber. But I was just wondering, is there anything specific intervention for that really young population that you found that might be kind of out of the box that's really helped them sort of progress to get those like motor milestones in when they're little?
I have not.
Okay.
I have not found a magic pill to make things like progress quicker.
Yeah.
I've done a lot of, we get a lot of families coming in saying, hey, there's this thing, and what do you think about it?
Yeah.
And in general, as long as it's not hurting the child and it's not taking up too much of your time and effort, then I don't recommend stopping it. But also from like a scientific standpoint, there's not a lot of scientific support for any of these kind of out-of-the-box things. So just, you know, as long as you're aware of that, then I think making decisions for your family is what's best for you.
I agree. No special pill. I think if you're seeing changes, right, follow your gut. You're a mom and you're a PT. You got the double whammy, right? So you're going to set up environmental situations and motivational circumstances that she enjoys that are going to encourage her to move into those positions, encourage symmetry. You know, I think it's pretty intuitive, truly. You're going to optimize alignment, these things, these age-old, you know, gold star characteristics of PT, I think really do come into fruition here in the long term, and not trying to jump stones.
Okay, thank you.
Yeah.
Okay, well, we are 5 minutes past, and so I want to thank you all so much for your time and contributions today. We are so grateful for you participating on this panel, and thank you all for being here, and again for your understanding. And now I'm going to pass it over to Sarah and the nutrition and gastroenterology session that will start right now.